Motor neuron disease, MND, is a group of neurodegenerative disorders affecting upper motor neurons, UMNs, lower motor neurons, LMNs, or both. 1. Amyotrophic lateral sclerosis, ALS, most common form, 80 to 90%, UMN plus LMN involvement. Limb weakness, spasticity, muscle wasting, fasciculations, hyperreflexia. Bulbar symptoms may occur. Median survival, 3 to 5 years. 2. Primary lateral sclerosis, PLS, pure UMN disease. Progressive spasticity and stiffness. Hyperreflexia, extensor plantar response. No significant muscle wasting or fasciculations. EMG is normal or shows only minor nonspecific changes. Slow progression. Survival often exceeds 15 to 20 years. 3. Progressive muscular atrophy, PMA, pure LMN disease. Muscle wasting, weakness, fasciculations, reduced reflexes, no clinical UMN signs. EMG shows widespread denervation. Around 1/3 of patients eventually develop UMN signs and are reclassified as ALS. 4. Progressive bulbar palsy, PBP, predominantly affects bulbar muscles, dysarthria, dysphagia, tongue wasting, and fasciculations. Emotional lability, pseudobulbar effect may occur. Often progresses to classical ALS, poor prognosis. 5. Pseudobulbar palsy, within ALS or other disorders, pure UMN bulbar syndrome, spastic dysarthria, dysphagia, brisk jaw jerk, emotional lability, usually reflects bilateral corticobulbar tract involvement rather than a separate MND. 6. Flail arm syndrome, brachial amyotrophic diplegia, variant of ALS, predominantly LMN involvement of both upper limbs, marked wasting of shoulder girdle and arm muscles. Legs and bulbar muscles are relatively spared initially, slower progression than classical ALS. 7. Flail leg syndrome, variant of ALS, predominantly LMN weakness beginning in the legs, slow progression, better prognosis than classical ALS. 8. Respiratory onset ALS, presents with respiratory muscle weakness, dyspnea, orthopnea, morning headaches, limb weakness appears later, poor prognosis. 9. Bulbar onset ALS. Initial symptoms are dysarthria and dysphagia, common in older patients and females, more rapid progression than limb onset ALS. 10. Juvenile motor neuron disease, onset before 25 years, often genetic. Genes include ALS2, SAKX, SPG11, FUS, slower progression than adult ALS. Hereditary motor neuron diseases. These are genetic forms that may resemble ALS or PLS. Juvenile ALS, hereditary spastic paraplegia with motor neuron involvement, Brown-Violetto-Van Laer syndrome, Kennedy disease, spinal and bulbar muscular atrophy. Spinal muscular atrophy, SMA. Although traditionally considered a separate disease, SMA is also a motor neuron disease. Pure LMN degeneration caused by SMN1 gene mutation, types 1 to 4 based on age of onset. Effective disease-modifying therapies are available. Kennedy disease, spinal and bulbar muscular atrophy, X-linked recessive, androgen receptor gene, CG repeat expansion, LMN weakness with bulbar involvement, gynecomastia, infertility, testicular atrophy due to androgen insensitivity, very slow progression. Classification by motor neuron involvement, disease, UMN, LMN, mnemonis, yes, yes, PLS, yes, no, PMA, yes, PBP, mainly LMN bulbar, initially yes, pseudobulbar palsy, yes, no, SMA, no, yes. Kennedy disease, no, yes. High-yield exam mnemonic ALSP3SK. A. Amyotrophic lateral sclerosis, UMN plus LMN. P. Primary lateral sclerosis, UMN. P. Progressive muscular atrophy. P. Progressive bulbar palsy, bulbar LMN predominant. S. Spinal muscular atrophy, LMN. K. Kennedy disease, LMN, X-linked. For DM neurology and board examinations, the core MND spectrum consists of ALS, PLS, PMA, and progressive bulbar palsy, while the remaining conditions are recognized variants or hereditary motor neuron disorders.